Welcome to part 2. Here we're going to be covering the kind of clinical signs that you might be seeing in cases that should raise your concern regarding leishmaniosis. We'll also cover some of the changes to routine haematology and biochemistry that may also be there as well. And we'll cover the diagnostics to more definitively diagnose this infectious disease.
In terms of the clinical signs that we can see, for some of these cases, and actually probably the majority of cases that you're going to see in practice that you may not even know have leishmaniosis, they'll have subclinical infection. We might also get some really early hematological changes and organ dysfunction. They may not be apparent either. Some dogs we see having very chronic, non-specific illnesses. We might see weight loss. We might see a touch of vomiting, inappetence, or diarrhea, and the appetite can wax and wane in that, particularly as they become systemically inflamed or not. We can get this, progressive dermatopathy, and I think this is going to be the classical form of leishmaniosis that we tend to think about, that we see in the books. And we can see a really poor little dog in here that's clearly incredibly pruritic. And one of their problems is leishmaniosis, but they have other issues too. They'll often get secondary bacterial infection as well. We do need to think about managing that too. So the classical signs that we see in dogs from a skin point of view is going to be this kind of grey, flaking dermatitis, particularly that's very often very symmetrical, associated with the face, and we can see in the periocular area, around the muzzle, around the ears. We may also see nodule formation, and these reflect little granulomas of parasites, driven granulomas, that areas where the dog's most likely to be bitten by the sandfly. So in and around the head and the neck area, sometimes around the leg areas as well. We may also see a polyarthropathy, and probably they're going to make up a large proportion of the cases we see in a referral centre. And these dogs present with grumbling, shifting, lameness. They will often, but not always, have quite a marked kind of effusion in multiple joints. And these are the ones that don't necessarily present with quite such an acute history as we would imagine are classical immune-mediated polyarthritises that we see that are non-associative. These cases also, when we look at their blood work, don't tend to be as inflammatory as some of those with kind of non-associative polyarthritis either. We may also see in them evidence of kidney dysfunction. Dogs with leishmaniosis will always have a minimum of virus 1 chronic kidney disease due to the damage that they get with the antibody antigen deposition in their kidneys. But they may have progressed to having kind of overt clinical signs associated with the kidneys, such as polyuria and polydipsia. We can also see ocular involvement, so we can see ocular discharge, and you can sometimes, when you look really closely at the conjunctiva, see them being quite kind of knobbly and nodular in pattern. And again, this is because it's a lymphoid tissue in the conjunctiva, and we're seeing that becoming inflamed, and that's a site where we can do some rubs to testing for that. But you can also get intraocular involvement too with uveitis, and that can be really quite severe and nasty, and there are some that recognise it as a separate issue. We may also see epistaxis, again for multiple reasons. You can get granulomas and ulcers forming on our mucosal surfaces. We can also get a hyperglobulinemia resulting in increased viscosity within our blood, and a hyperosmolar type process happening in there with hypertension. But the way I always think about it with these cases is that until proven otherwise, so this is until we've done the testing, and even sometimes in the face of negative testing, I will not completely remove it from my possibility list, is that we should be suspecting infection with leishmania and also ehrlichia too. They like going hand in hand in any dog with a history of travel to southern or southeastern Europe presented for veterinary attention. So I would, where possible, want to be testing these dogs to know that they have it on board, either as the cause or a contributor to their clinical disease, or a potential reason to be cautious before I put them under too much stress, either with medication or the procedures that I'm about to do to them. So other things might raise flags that we could be dealing with leishmaniosis. First things first, none. So some of our patients may have no clinical signs associated with Leishmania itself. They may have no change on their blood work at all, and they may still be infected with Leishmania. We know that subclinical infection is common, and actually, if we think about all the dogs that are exposed to Leishmania in the continent, given how prevalent it actually is, probably the majority of dogs will show no clinical signs at all following exposure to these organisms. We tend to see the cases that are developing clinical disease associated with it, so that's where we start to get those changes. And those changes are on a massive spectrum. They can start off being kind of very non-specific. We can sometimes just see very mild changes, all the way through to sometimes very severe ones as well. So we might be seeing mild, moderate, severe cytopenias, particularly neutropenias, but we can also get thrombocytopenias as well. And then in the later stages, we might also see anemias occurring too. We can also see mild through to severe hyperglobulinemia as well, and some of the more spectacular hyperglobulinemias that we see are going to be in association with leishmaniosis or potentially ehrlichiosis, or the two. And these are going to be our major differentials when we've got a case in front of us with hyperglobulinemia, where the alternative differential for that is going to be some sort of B-cell neoplasm, as an example. Yes, there are other differentials for hyperglobulinemias, but B-cell neoplasms, Ehrlichia and Leishmania are the biggies that we're going to be usually thinking about ruling out to start off with. One of the ways that we can try and help ourselves to rule things in or out, or at least help stack the cards in the direction we want, is to do a serum protein electrophoresis, and we can see a trace on here on the right. And this is where kind of we'll be kind of thinking about how we look at it. And in dogs with leishmaniosis, most frequently we'll see a broad-based spike, a kind of broad-based kind of hump, as it were, in the globulin region. But we might start seeing that narrowing down, and in some dogs with leishmaniosis, we might start to see a restricted oligoclonal spike that can sometimes mimic a monoclonal gammopathy in there. So it's not perfect doing serum protein electrophoresis, but it can sometimes help us at least stack the cards, whether it's in the direction of leash or whether it's in the direction of a B-cell tumour. Personally, I don't tend to do it very often. I don't tend to do it with monitoring in the cases, mostly because I have other tests that I rely on much more, and the turnaround time. Because I'm going to get results back kind of after a week or so, and there are other tests that I would rather do kind of more that have a shorter turnaround time. There is a lot of interest in some of our inflammatory markers or acute phase proteins, such as C-reactive protein. We do see it being often kind of mild to moderately increased in our dogs with leishmaniosis. There's more studies that are likely to come out in the next few years looking at that in dogs with leishmania on the continent, to try and determine how helpful it is to us in terms of response to treatment and identifying cases that are relapsing. I will sometimes look at it, particularly if I have a case and I'm worried that it's clinically looking normal, but whether it's on that relapse pathway. And what I have found it to be quite helpful in is when I've had a case of polyarthritis, and I'm trying to work out whether or not it's one of our like non-associative polyarthritises versus our kind of whether it's associated with leishmaniosis. And interestingly, the non-associative ones tend to have really cracking C-reactive proteins, whereas the leishmania ones tends to be kind of mild to moderately increased, not really, really high. And in some cases, that's what's kind of raised a flag in a non-travel dog going, could this be leishmania, because the C-reactive protein has not been as high as I'd expected it to be. We'll also frequently, as triggers, think about urinalysis. So we might see evidence of a glomerular nephropathy with a significant proteinuria, which might want to trigger us to think about leishmania. Our dogs with leishmania may also be at increased risk of urinary tract infections because they're immunologically crippled when they're in the kind of throes of disease. We may also see evidence of loss of urine concentrating ability, particularly if they're azetemic too. Again, we do worry about that. It's something we keep an eye on in these cases. Cytology wise, when we do aspirates of lymph nodes that may be big, if we do a conjunctival rub and have a look at that, if we aspirate the spleen, for example, we might see evidence of granulomatous inflammation. If we're really, really lucky, we might see evidence of organisms themselves, particularly if we know to look out for them. So some of the changes that we might see on here, like those cytopenias, hyperglobulinemias, proteinurias, we might thinking about, triggering some of thinking about testing in some of those cases. But otherwise, we're often looking for other things that we're going to need to be wanting to monitor. So another thing that we see coming up every now and again is, if you have a case in front of you and you're thinking, could this be Leishmania? How do I test for it? So we'd be recommending reaching for serology to start off with. It's a very, very good place to start, but it is an indirect test. So you're looking for evidence of the host response to infection. It's possible to have either quantitative, semi-quantitative, and qualitative tests. So the qualitative are, yes, no, I've got evidence of kind of exposure to this organism versus the how much antibodies am I producing against it. It's really kind of good from a screening point of view with a few caveats. So about half of dogs that have been exposed will be seropositive after about 5-6 months following that exposure event. But so if we've seen a dog that's relatively recently travelled, they may be negative. And they may start to show clinical signs before they become seropositive as well. So a negative result, even with overt disease, doesn't rule out infection, particularly early infection. But it would be relatively unusual for us to see that. We can also see infected dogs with positive, sometimes quite high positive results without overt disease, and they may never go on to develop disease as well. So it can be a bit more challenging to identify with those. So again, the higher the antibody level, the more concerned we would be that we could be looking at active leishmaniosis. And these are the cases where we definitely go back to them, look for any other changes that we might expect with leishmaniosis, and possibly do some other testing like PCRs, aspirates, looking for more supportive evidence, definitely looking at our heme and our chem as well. Now, we can also think about some direct testing. So say, for example, if we're aspirating our lymph nodes, we can go straight to looking cytologically for it. Specificity tends to be reasonable, particularly because we're going in there with a kind of a high level of probability already. But sensitivity is not great. So we're not going to be wanting to use that as a screening test. And we know that the distribution can be really, really variable. As well as lymph nodes, we can also do cytology of other lymph tissue like conjunctival rubs. We can do it for aspirates of skin lesions as well. And I've also looked for organisms within joint fluid too. It's also possible for all of those tissues to submit them for PCR and also to submit blood, whole blood for PCR as well. So this is, again, it's direct testing. It's looking for the organism being present within the fluid or tissue that we are submitting to the laboratory. But we get variable distribution. We can get infected dogs with disease, clinical disease, that can be negative on those PCR testing. And that's why we would frequently be wanting to reach for serology in those cases first. But we might be wanting to reach for PCR, particularly in early days of infection or where they're kind of sitting on the fence as to how overt they're being with their disease. And we can also get positive results in dogs without clinical disease. So finding a positive antibody test, finding a positive PCR test does not necessarily mean that we need to treat them.
That's the end of part 2. We now have a dog that we've diagnosed as having leishmaniosis. Part 3 will be covering treatments. Again, if you need some more information or need to take a break and have a read around, look at the QR codes and you'll find some online information that we have on there as well.